علي في الميكروفون تاعك.
See the 11th nerve and the more extending of the posterior occipital bone. Now we can see the VA, and once we retract of the VA,
Yeah, we start in 15 minutes. Oh my God. Is that Warlick's? Is that Warlick's? Welcome, everybody. We start in 13 minutes. Everybody comes at the last minute.
Hi, John.
Hey, how you doing, Warlick's?
I'm good, but I'm working today, so I don't know if I have patience.
Do you have your camera working?
Yes, it's a very, very small, like, phone because today I'm working. Yeah.
Yeah, okay. So I better announce, okay?
So what you gonna tell me something?
Well, I better host myself, okay? Because it's difficult for you, right?
Yeah, yeah.
Yeah, I know. We can't go back and forth. Yeah, we were supposed to televise another conference, but we just got disconnected from the Complications Conference, the Kiki Terrell in India.
Oh, yeah.
Yeah, you ought to check it out. The interface is very interesting. Where you watch that and you're able to go visit vendors. It's very nice. You check it out.
Yeah, I have already registered. It's
Yeah,
gonna be
go there.
today, right?
You'll see when you watch it. It's wow, this is different.
You see my presentation?
Everything's okay. Go
Hey,
ahead.
hey, Ben, how you doing?
Okay, thank you very
Fine.
much.
Hi.
So I will
Hi,
go
Professor Juha.
Hello,
Go.
John.
Hi. Hi, Marok.
Hey, Juha. Hi, good morning.
I will skip some of the general data. We know all.
We have some interference there. Someone's playing something.
But the problem in ruptured giant aneurysm is that there are difficulties to treat by either surgery or flow diversion. So regarding the indications for
So how many today, Ben?
those with
Today,
which are not made
yeah, I have 14. 14.
Oh, God.
in
That's a
6
busy, that's a
hospitals.
busier than usual, or is that a normal day?
There are two men
Quite one of the most busiest day in my career.
in
Yeah.
the literature.
Really?
Mhm.
Oh, okay.
Promoting some
Congratulations.
techniques, rapid ventricular pacing, but this
We televised Dr. Krish and Dr. Lawton, but we had a Chinese fellow from Dr. Krish's Arkansas Neuroscience Center, Dr. Lee.
Lee.
Yeah,
I know.
yeah.
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 I know him. Yeah.
Oh, okay. Yeah. He's from Shanghai,
too.
right? He's from outside Shanghai, I think.
But also many other techniques in order to solve these complex cases. So our case, it's a male, 59.
There's the king. The king has arrived.
Hi, Juha. Hi.
Hello, John. Hello, Atul.
Hi,
Hello, Subin.
Zubin. Everything okay?
Yeah, Warlocks is here too, but she's in the hospital. Say hi, Warlocks. Unmute.
Hi.
There you go.
Yeah.
She's on duty. Let's see here.
Juha,
Yeah,
to talk on AVM is difficult. It's not easy to talk on AVMs.
you will do well. You are such a passionate lecturer. My wife is calling you bullet train. You're going.
No, to talk on
I
AVM
know.
is
Was narrow, so
Yeah.
once we
I heard your presentation about the AVM. It's very good. Yeah,
It's wonderful.
fascinating.
Wonderful.
Yeah.
I hope.
Yeah.
But
Good to repeat.
it is not
Mhm.
easy, not
this is the
easy.
surgery, we perform a frontolateral approach.
You have some experience. That's your experience will come to the fore. Yeah, Kiki has a rather large webcast he's doing from Mumbai. For your buddy, Kiki,
Yeah.
your associate in Mumbai,
The proximal control.
the Mumbai
We
Mafia.
decide to dissect a little bit the-
Going on? That is going on now?
Yes. I actually am the panelist for this session.
Because
Oh,
Yeah,
that's what
yeah,
the
yeah,
noise
yeah.
is.
Yeah.
Multitasking.
Yeah, he didn't want to put it on YouTube, so I can't televise it.
I will speak tomorrow for Kekitura.
Oh, you're speaking there tomorrow?
Tomorrow, yeah.
Oh, great. Okay, and you got a speaker already for next week, right?
Yeah, this is Atul Goyal. It's next week.
Oh, you're doing again, another one, okay.
Yeah.
I thought I got an email from someone that is confirmed. I guess it must be the week after.
Next week I am there, Juha or Ugur? You said Ugur.
Wait, I have to check.
Yeah,
Yeah, I'm not sure either. Anybody else in the panel want to say hello? I'll check in. Abby's here. Hello, Abby. You there?
John,
You can't escape. You can't hide.
I can't hide.
No,
You'll find me.
no. Your name's there.
Ugur is next Friday. Yeah,
Okay.
that's right. You were right. Sorry. March 12th is Ugur. Yeah. And then again, Atul.
Okay. How's the situation in Mumbai, Atul, with COVID? Is it getting better, staying the same?
COVID, now the life is normal. Now there is a lot of crowd outside. People are moving around. Hospitals are running normally, but the numbers are a little bit up recently in the
Okay.
last 1 week. Maybe here and there. But people are getting vaccinated now. Many people, I have also got vaccinated twice. So
Right.
vaccination is being done. So let us see. What about China? Juha?
Yeah, we have 0 case for maybe
It's
half a
amazing.
month.
That's
Yeah.
amazing. That's amazing. That's amazing. You know, I look at Mauro. Are you there? Mauro Seguro from Mexico. I think it's kind of rough down there. Mauro, you there? You there?
Yes, yes.
How you doing, Mauro? Mauro's from Mexico. Mauro, how are things in Mexico with COVID?
How is COVID? Terrible. Mexico
Really?
is in the second peak, but in decreasing time. But
Oh, okay.
the last 2 months has been very difficult for Mexican.
Right, right. So not getting better, huh?
No, just beginning with the vaccine, but less than 1% of the population.
Okay. Very good.
Thank you. Good morning, everybody.
Mauro, have you met Juha? Have you met you there?
I'm here. I'm
Yeah, I'd
here.
like to meet Mauro Seguro. He's a Mexican neurosurgeon. He likes to televise. I see you little televising things, Mauro.
Yeah, Professor Juha.
Yeah, yeah.
Hello. Hello.
We met here in Mexico 5 years ago with Dr. Edgar Natal.
Is it already 5 years? Yeah. The time is running. Yeah.
I have your book.
Yeah.
Thank you
Yeah,
for
welcome, Mauro. Okay, you start in 4 minutes. So, thank you.
Juha, how many people
Yes.
in the world? How many people in the world you think are doing AVM surgery? What is your impression in the world?
I cannot. This is. I have to think about it. So,
My
how many
feeling
in
is
China? How many in China have been?
Actually, my mentor, Professor Shi Yuquan and Professor Chen Xiancheng, and now totally in Huashan Hospital, we have around 1,100 cases of AVMs. And I think, yes,
altogether.
1,001. Yeah. And I think Tiantan Hospital, they have even more cases than us. So they in AVM, I think they have around 1,000 or near 2,000. Yeah.
So in order to understand the anatomy,
but it's only for open surgery. You know, for the embolization, normally we have. I personally have around 60 cases of AVM per year, including the interventional treatment and the open surgery.
And that's the place, and this is how I imagine the aneurysm is located inside the parenchyma. So I continue my dissection.
Okay, 1 minute. 1 minute, Atul. I guess you're not even nervous. You don't have any butterflies or anything, right?
Well,
it's like brushing your teeth. Okay, we'll let a few more people in and we'll start. It's always a last minute rush.
See, too many things going on at the same time, John.
It's not too bad, actually. We have weekends get a little tight. but it's much less than before. There was a peak about 2 months ago, but it's kind of slowed down actually. But anyways.
Hello, Professor Atul.
Hey, good morning, Victor.
Hello, Victor.
Hello, Professor Juha.
Hello, Victor.
And
Hello,
again,
Victor.
I go to the computer and I have
Okay, we're ready to start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach. It's really like that. We have the pleasure of having another Juha's neurosurgery grand rounds from China. And today we have another presentation by who I call the king of Zoom. He's ready to teach anywhere. He's ready to teach neurosurgery anywhere. And we'd like to welcome him. And I'd like to have Juha introduce Atul. Welcome, Juha.
They're all.
Did you want to share something, Juha? Okay, there you go.
Just,
There you go.
I saw the same, because Atul is the same. Atul is the king of Zoom, like we are calling him. So he's a professor and chairman at King Edward's Hospital, and he's one of the most important neurosurgeons of these times in the world. This is certainly true. So how to become a good neurosurgeon? Train hard, follow the way Professor Atul Goel is doing. He has huge manual skills, but also good thinking. You need to do 10,000 hours of training. This is the classical rule, and my rule is 10,000 days in operation room, and this is the case by Professor Atul Goel. Neurosurgery has 3 parts: operative skills, research, clinical and basic, and then teaching. So Atul Goel is doing huge number of operations every year, 1,500 operations, and this I have concluded you have to be excellent neurosurgeon, but also organizer, surrounded by good supporting team and the patients and society. And of course, you have to work in a big country to have a good flow of patients. He's a good teacher. He's teaching young people to become better than we. This is very important principle. He was selected a few years ago as one of the most important neurosurgeons of the century. 69 the neurosurgeons here, and here he is in extremely good company of Cushing and the Yasakil. So without speaking more, I let Professor Atul Goel to give his splendid lecture on surgery of cerebral AVMs. So let's enjoy. Atul, please.
Yeah, thank you, Juha. And it is my great honor and absolute privilege to talk on this subject of AVM in the Juha Symposium. Needless to say, Juha is one of the most celebrated neurosurgeons of our times, one of the most technically profound neurosurgeons, one of the most loved and affectionate neurosurgeon of all times. And he has influenced so many young neurosurgeons all over the world. So whenever you go to any conference, any meeting, the name of Juha comes in. So thank you, Juha, for inviting me. And I'm going to talk on my very favorite subject, and that favorite subject is arteriovenous malformation surgery. Arteriovenous malformation surgery is difficult. It is dangerous. It is absolutely technical. It is absolutely philosophical. You need tremendous skills to do AVM surgery. But if you do it properly, you give new life to the patient. And there is no other treatment for AVMs, surgery and surgery alone. Bleeding is our life, a neurosurgeon's life. Bleeding, bleeding, bleeding. And I have been in blood all my life. Bleeding is a part and parcel of all my surgical cases. For last 40 years, I have been struggling to deal with bleeding and get hemostasis. So this is a neurosurgeon's life. How you deal with blood. When bleeding occurs, how you control it. You use bipolar, you keep unipolar cautery, you use bipolar cautery, you get terrified, you start jumping, you start running, you start moving, you start shaking, your blood pressure goes high. When it bleeds, how you control yourself, how you control your team, and how you achieve hemostasis is an absolute art. And that art has to be learned over several years. How you distinguish one neurosurgeon from other is how the neurosurgeon controls bleeding and how he reacts when bleeding occurs. So this is a very important part of a neurosurgeon's life. And blood, I call, is a miracle of God. What differentiates dead body from alive, a cadaver from life, is flowing blood. I like to call blood as soul of the human body or life of human body. Blood is life, blood. Hemostasis, when bleeding occurs, if you cut the skin, bleeding will occur, and how hemostasis occurs, coagulation factors, this factor, there are so many factors which come into existence, and how hemostasis occurs. The more we know, the more we do not know. So these are some philosophical sentences. I addressed him, God healed him. The art of healing. You take an incision, the skin heals. This art of healing is absolutely divine, and God has created this art. This is another very beautiful sentence from a French neurosurgeon, Ambrio Pare. I caused the bleed and God stopped the bleed. Art of hemostasis and art of wound healing are divine arts. And if a surgeon has to pray to one God, and that God will be the God of healing, the God of hemostasis. So I have been dealing with bleeding situation for several years of my life. So this is one case I did in 1994. You can imagine the arteries encased within the confines of the tumor, how you can remove the tumor, how you control small blood vessel, how you dissect in the subarachnoid plane, how you protect the arteries, and how ultimately you come out victorious are very, very important, very important. This is another tumor, which was a very vascular tumor. You can see the angiography. And this tumor was operated in some other institute, and he did retrosigmoid operation. He touched the tumor. He just touched the tumor and he lost 4 liters of blood. And then this patient came to me and I did a very extensive petrosectomy. And by the time I touched the tumor, I lost 4 liters of blood. So and this is a young man and he was having only some kind of giddiness. So I said, this is an inoperable tumor. And I sent him home. Then I tried, but he came with extensive giddiness. He came back and you see, this was the angiogram I did. And during that time, I did balloon occlusion test. I thought, let me occlude the carotid artery and common carotid artery. But as soon as I occluded the carotid artery, he developed weakness. So I released the balloon. So it was a difficult situation, but I removed this tumor. You see, I removed this tumor completely. There is some post-operative change here in 1995. So this was one of my most vascular tumors. I occluded the carotid artery open, occluded open, occluded open during the operation, and I removed this tumor. So this was one vascular tumor during that time. This is another very dangerous tumor. This is not very dangerous. This is quite a straightforward tumor, but hemangioblastoma. And you can imagine the relationship with medulla and very intense, very huge vascularity. You touch the tumor, it bleeds. So you have a style of removing hemangioblastoma. You enter into hemangioblastoma, you can never come out. You have to go around the tumor, get feeders, and it will not be hundreds of feeders. There will be very few large vessels. So there is a style, there is a technique of removing this hemangioblastoma. And hemangioblastomas is a benign tumor. If you are able to remove, you give new life to these patients. So there are various types of tumors where vascular tumors, non-vascular tumors, heavily vascular tumors. This is pituitary tumors. Now, if you enter into pituitary tumor, it will bleed, and it will bleed heavily. But if you go on coagulating, you will never be able to remove this tumor. This tumor has to be broken. This tumor has to be attacked. This tumor has to be demolished. You don't have to go on coagulating. If you go on coagulating, you will never be able to remove this tumor. So the art is demolish the tumor and the whole tumor will remove. There is no need for coagulation. Similarly, for acoustic neurinoma, if you go on coagulating in the tumor, you will never be able to remove the tumor. You have to coagulate in acoustic tumor very selectively and very pointedly. You cannot just go on coagulating all the time. So when to coagulate, how to break the tumor, how to dissect are very critical issues in our neurosurgical life. So these things I have mentioned in even craniovertebral junction. To operate in the craniovertebral junction is quite a vascular. There is tremendous venous bleeding in the lateral gutters. So one is cavernous sinus venous bleeding, one is lateral gutter venous bleeding. Both are equal and both are quite heavy, and you have to be strong. So the issue is, my advantage with me is all my life I have been in blood and in heavy bleeding situation, and bleeding control has become a part of my life. Arteriovenous malformation surgery is absolutely the last chapter of our subject of neurosurgery. If you have to remove arteriovenous malformation, you have to be absolute master of the subject of neurosurgery. You have to know your own skills. You have to know your own issues, whether you can remove it or whether you cannot remove it, whether you will be able to remove it, whether you will be able to operate and come out successfully. You have to know your own self and you have to decide. Arteriovenous malformation is the last chapter of neurosurgery. If you ask me which is the subject in neurosurgery which excites you most at this point of time, I will say I love AVM surgery. And whenever I have to operate AVM surgery, I think I am quite excited. As far as AVMs are concerned, we all know that AVMs are benign problems. AVMs are not cancerous tumors. The issue is what are the types of treatment? In my calculation, I'm not arguing with others. I'm not saying what others like, what others do not like. I am saying for AVM, there are only two types of treatments. One is surgery. You remove the AVM. And one is do not do anything. So my strategy is, when I see the patient, I will say, yes, I can operate, and I will operate, and I will remove the AVM. If I think that I am not able to operate, then I will say, go home, don't do anything. So these are the two things. I do not like partial embolization. I do not like embolization following surgery. Preoperative embolization, I do not like. I do not think that preoperative embolization will help my surgery. So this is a little bit controversial thing, but this is what I feel. And I feel that radiosurgery is indicated in only very, very rare situations. So this was a smallish article which I had written several years ago. So when you are operating on AVMs, what is most important is the nidus. So this is the nidus. This is the AVM nidus. So you have to know where is the nidus, what is the flow in the nidus, whether it is slow flow, whether it is medium flow, whether it is very heavy flow. So it is very critical for the neurosurgeon to identify from the angiography and from the AVM architecture whether you are dealing with a slow flow AVM or a medium flow AVM or a high flow AVM. It is absolutely critical because this will determine your surgery. So the location, this AVM is located in the frontal brain. So it is a little bit of a good brain to operate. Even if you sacrifice brain, there is little or no harm. This AVM is a parieto-occipital AVM. This is the more common region of arteriovenous malformation. But if you see this AVM, there is a flow-related aneurysm. There are intranidal aneurysms, multiple intranidal aneurysms. The vessels are large, feeding vessels. So this is a high-flow AVM. Even if it is a relatively good area to operate, you must remember before operation that you are dealing with a high flow and it will bleed, and it will bleed furiously during operation. This is one AVM which is fed by large blood vessels. So my feeling is when there are multiple large blood vessels, it gives you a little bit ease of operation. You come here, coagulate here, clip here, and then you can resect the AVM. So large vessel AVM are better AVM. This is an AVM which multiple small vessels. You see multiple small vessels. But the good thing in this AVM is the drainage is large and almost single. The other thing that bothers me is whether the AVM is being drained by superficial drainage vessels or deep drainage system, internal cerebral vein, vein of Galen, straight sinus. So that is also very important. So the nature of nidus determines your surgery. This is another kind of a diffuse nidus. You see, it almost looks like two niduses, but these are one compact one nidus and having located in the depth. Now, whether this AVM is amenable to surgery or not amenable to surgery is a very critical issue that one has to decide. This is a diffuse nidus. And you see here between the nidus, there is brain matter, and whether this is an AVM itself or whether it is another kind of vascular malformation, you have to decide for yourself, but this is a different kind of nidus. So one thing, when I see the patient, there are 2-3 things I see. One is, what are the symptoms of the patient? Whether this patient has had a bleed, whether this patient is having headaches. Severity of headache is very important. When the person is having severe headaches, it is a high flow AVM. When the person is coming with a bleed, it is a high flow AVM. Low flow AVMs will not come with a bleed. When the patient bleeds, it is a high flow AVM. So I will see the patient and I will see the angiography and I will classify my AVM into 4 grades. One is easy AVM. Easy, of course, easy is a very complex word in neurosurgery, but it is easy for, it is possible to remove. The other classification is difficult but safe. Very difficult and risky but possible. not safe or not possible. So this is my personal classification. And I call it a dynamic classification. With my experience, with more and more experience of more than 40 years in neurosurgery and at least 35 years or 30 years with AVMs, which were very difficult. Maybe now they are difficult but safe, which were difficult but safe, maybe have come into this category. So it is a dynamic classification for me. And it will differentiate what Juha will think that it is difficult. Maybe it is very difficult for me, or very difficult or not possible for me. So it is between, it is different for different neurosurgeons. Various things matter, like sight of the AVM, eloquence of the area, eloquence of the area. If it is in a motor strip, it is dangerous. If it is in the brainstem, it is dangerous. If it is in critical areas, it is a danger. So you have to know where is the AVM. The other very important thing is the number of vascular territories that are feeding the AVM is a very important. I will discuss this issue afterwards. Degree of flow of the AVM is a very, very important, very important. High flow AVMs are difficult and dangerous. Low flow AVMs are better. This you can, whenever I do AVM surgery, I prefer, I don't get to see all, but I will like to see angiography being done. And then on the angiogram, I can see how fast the blood is flowing. And there are various features to determine whether there is flow is high and flow is low. And symptoms determine headache, vomit, headache and bleeding. And aggressive symptoms are suggestive of high flow AVM. If the person is coming with multiple convulsions, it is high flow AVM. If the person is coming with higher functional dysfunction, maybe high flow. So more the symptoms, more aggressive the symptoms, more high flow is the AVM. So this is one AVM. The question is whether you will like to operate this or you will not like to operate. So whether first is you investigate. So the investigation, this 3D CT angiogram. CT angiogram is now becoming a very important tool to investigate AVMs. You see, this is a beautiful CT angiogram that you see where is the location. It is very important to know whether the AVM is outside the ventricle or inside the ventricle. Inside the ventricle is better to remove. Outside the ventricle, impossible to remove, maybe in this location. So it is critical to know exactly where is the AVM in relationship to the ventricle. You see, it is in the ventricle, and this is intraventricular AVM. So we made these kind of models earlier. Long time ago, we made these 3D models. Like you can make a model and then see the AVM. This is our first generation model, but we changed it. You see this AVM is entirely within the ventricle. You see the fiber tracts, corpus callosum around the. So intraventricular AVMs are relatively simpler to operate. And intraventricular AVM are more compact, and you can get to the feeders and you can remove. So intraventricular is a better operation. So we published this 3-dimensional models for AVM surgery, and this was the first publication on the subject where 3-dimensional models were. Now you see, this is the AVM and this is the model. If you have this model, 3D model, you can see exactly. If you see this vessel, you locate where is this vessel in this model. If you see this draining vein, you locate on this model. If you see straight sinus here, you locate on this model. And then you can design your surgery. These models have become very important for me during surgery. And you can hold the model in your hand, mark the thing exactly where you are going to operate, and then make an incision how to operate, and then you can remove this AVM in a better fashion. So these 3D models are very important. And this is another 3D model. You see, beautiful model. You can you can see the extracranial vessels supplying this AVM, and you can see intracranial vessels supplying this AVM. So now let us go for AVM surgery. Now this is a young little girl who comes to me with severe headache. And you see her hair here and there and her hands on the head. And this is the AVM. So this is quite a, I'm not saying very difficult, but it is quite a difficult AVM. And you see this model and you see the AVM. Now the question is whether you will like to operate this girl or you will not like to operate. You cannot say I will embolize 20 times, 10 times, and then I will operate. I think if you do 10 times, you will not, you may not be able to see this girl again. The question is, if you operate, you must operate and remove this completely and cure this person. Surgery and surgical resection is curative, but it is difficult. And you can create hemiplegia following surgery. You can create death following surgery. So if you are planning surgery on this patient, you have to be absolutely sure. You have to be 100% sure that you will be able to remove this AVM, and you will be able to remove it completely, and you will be able to remove it safely, and there will be no deficit for this patient. And if you remove it safely, you can bring smile on the patient's head and on the doctor's face, and you have cured the person. Now this girl will live normal life and headache-free life. And if you were not able to remove this AVM, she would have maybe not lived. The headaches would have continued and she would have probably bled to death. Embolization is an option. I'm not talking of that option or not, but I think surgery, if you can do surgery, if you can do beautiful surgery, and there is no way you can say, I will do partial resection, I will do half resection. Half resection is good for tumors, but not for AVM. When you enter, you have to kill the AVM, not the patient. You have to save the patient, and you have to save the function of the patient. And you have to kill the monster completely. And if you leave small AVM behind, that will lead to bleeding, and that will lead to post-operative bleeding. And then don't blame normal perfusion breakthrough and all those things. If you remove it completely, there will be no perfusion breakthrough. The question is how to remove it completely and how not to leave residual AVM behind. So those are some issues which I will discuss. This is one large AVM in a young boy, a farmer by occupation, comes with severe headache. Headache means like the previous girl headache. And you see, this is the AVM. I said it is too dangerous for this guy to get operated, so I left him. But he comes back to me again after about 3-4 months, and the whole family says, doctor, you please operate. I must say one thing. It does not matter if the patient says you operate. It does not matter if the patient says, I consent to operate. It does not matter. The only one thing that matters in AVM surgery is whether I will be able to operate this AVM and whether I will be able to successfully operate and remove this AVM completely. That is the only. Consent and no consent, patient agrees, family agrees, does not matter. What matters is you find the AVM. This is large anterior cerebral artery. You can get to the feeders early in the operation and you remove this AVM. It's possible. And here is this is the preoperative angiography. You see quite a huge AVM, and this is postoperative angiography. This AVM is removed, and this patient is completely cured. Completely. He will now have this smile for his life, and there will be no problem. He is not having malignancy or glioblastoma, which will recur. There is no possibility of recurrence of AVM if it is completely removed. You cannot remove this AVM piecemeal. You cannot say, I will remove small pieces, small pieces. You have to dissect. And you have to identify the nidus, you have to get to the feeder, and you have to remove it, dissect. And you cannot go on coagulating and coagulating and coagulating. If you go on coagulating, you will never be able to finish this operation. You have to find when to coagulate, when not to coagulate, coagulate, cut, and then go on dissecting and get to the. This is another very aristocratic, very intelligent person, an Indian Institution of Technology engineer, and comes to me with only problem of seizures. There is no other problem, even there is no headache. So now this is when the person comes with only seizures, I will say the AVM is little bit less high flow. When the patient comes with headache, the AVM is more high flow. So this is the AVM. You identify, this has got very good points, large anterior cerebral artery feeders, little bit middle cerebral artery feeders to identify the nidus. One thing I'll tell you, all these large AVMs ultimately reach the ventricle, and there will be intraventricular choroidal vessel feeders in all large AVMs. So you operate from surface, and ultimately the most difficult bleeding to handle will be from the ventricle. So all the bleeding, major bleeding, all large AVMs will have bleeding from the ventricle and from the choroidal feeder. So that is, you must remember if you are going to operate on large AVMs. So these 3D models are very good for me. And this is post-operative angiography, and this is beautifully resected and dissected. You have to know the art of resection, the art of dissection, the art of controlling bleeding. If you will say, I will like to operate in a bloodless field, you should not operate on AVMs. You have to go on operating in a bloody field, identify the feeders, and go on removing the AVM. This is one, I will say, one of the easier AVMs. You see large vessels, MCA and PCA vessels in the convexity, and this is the dome of the AVM. I will say this is one easier AVM, but I have to tell you that there is nothing like easy AVM. There is nothing like easy neurosurgery. All neurosurgery is difficult and dangerous, but this is one of the easier ones, and you can remove. This is one more complex AVM. You see now, you will ask me, in this AVM, in proximity to the brainstem, in proximity to the vein of Galen, in proximity to the various complex structures located in this structure, how you will decide to operate? You see, you have to decide to operate. First is you have to identify if there are some good points in the AVM. For me, the good point is posterior cerebral artery feeder is a good point. You go interhemispheric, get on the tentorium, above in the region of the tentorium, get the PCA feeder. You see there is a large anterior cerebral artery feeder here, and this is ultimately, you see, you can get large ACA come interhemispheric. Interhemispheric exposure is a very important exposure for AVM surgeons. You have to know how to retract the cerebral hemisphere, wide, big exposure. For AVM, you cannot have endoscope or mini exposures or mini micro exposures. You have to have huge exposure for AVM surgery. Huge exposure, circumferential exposure, get the feeders, get the nidus, dissect the nidus, and you have to win. You cannot during the operation say that, oh, sorry, I cannot do it. Oh, sorry, I cannot do it. Once you accept that I will operate, you have to complete. Because if you are not able to control bleeding during operation, you will be lost and the patient will never be seen. You see, this is the AVM. Now you see this AVM, this is large posterior cerebral artery feeder. Now posterior cerebral artery is one of my big favorite points in AVM surgery. Come interhemispheric, identify the tentorium. Above the tentorium, you coagulate here. And then you dissect. And then once you get the large posterior cerebral artery feeder, this may not become such a difficult AVM. But I have already mentioned that large AVMs almost always have a ventricular supply, and then you have to dissect, and then you have to resect. And one thing you must remember, that if you are able to resect, you are able to cure and give new life and symptom-free life to these patients. This is another huge AVM, and it has bled. So it is a high flow AVM. Now, whether I will be able to operate, whether I should operate or not, you see there are intranidal aneurysms here. But the good thing for me is this large posterior cerebral artery. You see this large posterior cerebral artery? And I come interhemispheric to the tentorial edge, get the posterior cerebral artery early in the operation, and then get the other vessels, dissect, and then ultimately resect this AVM. So this is preoperative, and this is postoperative angiography, and this AVM has been beautifully resected, and this patient, without any doubt, has a new life. And I must also tell you one thing. I'm showing you preoperative and postoperative images. I must say that if I am able to resect the AVM, the recovery following surgery is beautiful recovery. Like you operate on glioblastoma, the recovery is not as beautiful. But you operate beautifully on AVM, the recovery, the patient will be postoperatively very bright. I'm not saying I had complications after surgery. I'm not saying, and don't misunderstand me, but I'm also saying that if you have done AVM surgery properly, the complications following surgery will be very far and few. Complications are not too many in AVM surgery if you are able to resect and dissect. Now, this is one AVM. I will ask you a question, whether it is easy AVM to remove or a difficult AVM to remove. Your answer may be because it is posterior cerebral artery and it may be easier to remove. Yes, it is a good territory to operate. You come get the PCA, but this AVM is a more dangerous AVM because it is fed by the middle cerebral artery. It is fed by the anterior cerebral artery. It is fed by the contralateral anterior cerebral artery. So this, when multiple territories are feeding the AVM, it becomes more high flow and more difficult and more dangerous AVM. So this is the AVM which I have resected. And I can only tell you that these are difficult operations, but they give you a nice kind of feeling if you are able to remove these AVMs. This is another AVM with a large PCA. You see this? I told you that PCA is my good friend. Get to the PCA. The question is whether you can get to the PCA. If you cannot get to the PCA, you cannot do AVM surgery. Matter close, don't do. The question is, get interhemispheric, have a wide exposure, retract the brain, go across along the tentorium, find the whole edge of the tentorium, find the PCA coming out of the tentorial edge, get to the PCA and then remove this AVM. Even if this is AVM, this is postoperative angiography showing complete and beautiful resection. This is another AVM which I resected just few days ago. During the COVID times, you see this is the AVM and this is postoperative. Anterior cerebral artery, come interhemispheric, get to the vessel and get to the feeder. You see these are when there is anterior cerebral artery AVM, those are interhemispheric, get the anterior cerebral artery feeder, and then I must tell you, not a very difficult kind of AVM. Now, this is one AVM which I will like to show you some steps of surgery. This AVM comes with a bleed. And this is located in the, these are anterior cerebral artery, this is anterior communicating artery, this is anterior cerebral artery here. AVM having multiple large aneurysmal dilatation inside the AVM in a critical area. So let me see if I can show you some steps of surgery. First and foremost is you have to have large exposure. And you see in AVM surgery, what I do is I use my right hand for suction. And then I go, in this AVM, I have a very wide exposure. I expose both optic nerves. I expose both anterior cerebral arteries. I go contralateral side, get both the anterior cerebral arteries under my control, huge exposure. You cannot have a small exposure in AVM surgery. Then you identify the anterior cerebral artery here. You know the anterior cerebral artery is the major feeder for this. And you also know that the anterior cerebral artery has several important vessels which you have to save. One thing you must remember, if you take one normal vessel in AVM surgery, you have killed the person. If you take one perforator which is normal, you have killed the person. So identification of normal from abnormal is the most important step during surgery. Once you have identified normal from abnormal, you have to first, this is of course my little bit oldish surgery. This is also a little bit old. Once you have coagulated, you cut. Once you have coagulated, you cut the vessel and then proceed with the dissection. You see my right-handedness. You have to identify normal vessel from abnormal. That is one thing, critical. You have to learn the art of controlling large vessel bleeding, small vessel bleeding, medium-sized vessel bleeding. And I must show that this is an edited tape. During the operation, it will bleed here, bleed there, bleed everywhere. It will bleed from one point, it will bleed from 2 points. These large AVMs are not easy operations, but this is the only treatment. Whether you will be able to accept the challenge, that will depend on you. Identification of abnormal vessel, coagulation and cutting of that vessel, then going on dissecting, identification. You see, I am then using little bit firmish dissection, and then I am going to resect this AVM, identify the vessel, and you see now there are multiple clips, and then I will retract the AVM over. It will bleed here, bleed there. Big vessel bleeding is relatively safer. Small vessel bleeding, and I must give you one message. If you understand these small vessels, if you know what are these small vessels, these small vessels form the basis of AVM surgery. These small vessel understanding forms the bottom line of your surgical strategy. Small vessel bleeding is the most critical point of AVM surgery. When you see small vessel, you do not have to coagulate. That small vessel will indicate to you where is the bigger vessel. Where is the mother of that small vessel? You go and dissect around the small vessel, go on continuing your dissection, and you will find a large vessel in the periphery of that small vessel. That small vessel, that big vessel needs to be coagulated. And I must say that if you understand small vessel bleeding, you understand AVM surgery much better. Coagulation in the small vessel may not be necessary, and then you have to coagulate around in the normal brain parenchyma, and you may not be even able to control that bleeding. Small vessels have to be identified. Small vessels have to be followed towards the mother vessel. Small vessel is the child of a bigger vessel and a bigger problem. You identify the bigger vessel and then you control that big vessel. Some people, what they do is small vessel, they keep on burning, and that is the issue. You lose the small vessel, and then there can be post-operative death, and then you blame normal perfusion, pressure, breakthrough, and all those kind of things. You should never misunderstand small vessels. So this is the AVM. I must say that if you are doing AVM surgery for 20 hours, then you cannot do AVM surgery. You have to rapidly do your dissection. You have to finish in reasonable time. If you are going on dissecting for hours and hours, it means you have wasted a lot of time. You have to find the arteries and you have to quickly get to the hemostasis. If you are doing for 20 hours, you can never do AVM. You have to finish in reasonable time. 3 or 4 hours is the biggest. Don't have to do more than 3 hours AVM surgery. If you are doing for more than 3 hours, you are doing 4 hours, maybe maximum. AVM surgery is a large operation. AVM surgery is a long operation, but long does not mean 20 hours long or more than that. So this is post-operative angiography showing resection of the AVM. This is another AVM in the Sylvian fissures. You see, Sylvian AVMs look very dangerous because they are normal vessel and they are abnormal vessels. So this is the Sylvian AVM. And let me show you the AVM surgery here. Sylvian AVM is to identify normal from abnormal. If you take one normal vessel, the Sylvian fissure, you will make 100% sure shot hemiplegia. So if you want to create hemiplegia, then you should not operate because patients have come for some, minor symptoms here and there. So if you have doubt, put a temporary clip. Then lead to the AVM. Once you have got to the AVM clearly, once you have identified the AVM feeding channel, only then you have to coagulate. Only then you have to coagulate and cut. If you have, if you just start coagulating here and there, then you can create a big issue. So you see what this AVM is, it is looking quite a flabby AVM, and normally they will not look like this. They will look like a bomb and they will burst. That bomb will burst. But find out the normal vessel. Then identify the abnormal vessel and then cut that abnormal vessel and then dissect the AVM circumferentially. It is not a difficult surgery. Many of these AVMs look very dangerous when you are operating and when you have seen the preoperative imaging, but they turn out to be quite a, these lions can be tamed, and these furious, ferocious bleeding is the one you should not. If you are afraid of bleeding, if you are afraid of massive bleeding, then of course you should not be coming into, then you should do embolization, and then you should do multiple embolization. And one of these AVMs will, during one of these embolization sessions, you will find that the patient will not come out, and that will be the end of the story. Needless to say for me that I do not think embolization is a good treatment for AVMs. Some people are saying, I'm not going to argue with them. If they are able to do, I will say, please go ahead and do. But for me, surgery is a beautiful option for AVMs. And I have a feeling that preoperative embolization is not such a great idea for me for AVM surgery. You see, the whole AVM is collapsed. You dissect and then you resect. I think, many of these AVMs can be very beautifully removed. And if you are not able to remove, you are decided to remove and you are not able to remove, then it is a disaster. So as I mentioned to you, the most critical thing for AVM surgery is before the operation. Before the operation, you see how the AVM has collapsed once I have taken the AVM major vessel, and then you can remove this AVM. Most critical thing is before the operation, you have to identify that whether you can remove this AVM or not. This is one AVM, like a huge AVM, but you see, this is like a pyramid. The whole brain looks like blood vessels, worms, but the entire circulation is coming from the anterior cerebral artery. And this, according to my calculation, is quite a safe AVM surgery. So let me show you some steps of this operation. I must also tell you, don't misunderstand this operation. Nobody can teach AVM surgery to anyone in few minutes or half an hour or 1 hour. You have to learn. You see, what I'm doing is I'm getting to the anterior cerebral artery like ACOM artery aneurysm surgery. Then I will identify, I have clipped the anterior cerebral artery, then I'm leading to the AVM. These are temporary clips. Then I will identify the huge vessel. You see, huge vessel which is going to supply this AVM, and then I will coagulate. Once I have identified clearly that yes, this is the vessel, I should not just coagulate the anterior cerebral artery. If I coagulate anterior cerebral artery, maybe nothing will happen. Maybe nothing will happen. But I should not do, which is not necessary. What I should do is identify the bleeding vessel. If I am having doubt, put temporary clip. If I am having doubt, I should not coagulate. If I coagulate one person, I have not come to kill the person. I have come to save the person. And I have come to give a new life to this man. This patient has come with severe headache. You cannot create hemiplegia here. You cannot create unconsciousness here. Because if you create unconsciousness, this patient will not die and he will remain unconscious for 10 years or 15 years. If you create hemiplegia in this patient, you have created hemiplegia for lifetime. So you have to be very, very sincere, very honest, very truthful to your own self. And for the sake of our subject, if you create one complication, maybe all right. It is not all right even if you create one complication, but complications happen in our surgery. Complications happen in our neurosurgical life. You do acoustic, you create a complication of facial palsy. These things happen in our life. If you say, I will not have complication, you are not truthful. But if you have created a complication, sorry for that. If you have created a complication, sorry for that, John, what is the issue?
Yeah, it's good now.
Okay. So if you have created a complication, you have created, these patients will not die because they are not having tumors. You have removed the AVM, so you may not be pardoned by the patient. You will say, okay, I have done 100 AVM, I have created 5 hemiplegias. These 5 people, you have created disasters. You have cured 95, but 5 patients will trouble you throughout your life. I am not saying you will not create hemiplegias or you will not kill these people. But if that happens, that is a bad complication and it should not happen. And you have to better avoid those kind of complications. So once you get to the correct vessel, you clip it and then cut it. So again, gradually dissect and get the AVM and remove this AVM beautifully. And it is, I have already told you that in my calculation, this is not a very difficult AVM to remove. And you can remove this AVM in a very positive fashion. It will bleed, wide exposure, big exposure, identify normal from abnormal, control large vessels, control medium vessels. Most important, number one issue is small vessels, small vessels, small vessels. They will lead you to the mother vessel. Don't coagulate small vessel. They will never stop. You coagulate surrounding brain, you will never stop. Small vessels should never be stopped. Follow these vessels toward the mother vessels and then cut. That mother should be handled. Children are to be ignored. Mother and the father of this AVM is sitting behind the children, and you will be able to ultimately resect this AVM completely. And there is no question, incomplete resection is not possible. Tumor, meningioma, okay, I remove partially. Acoustic tumor, okay, I remove partially. It will be okay for the patient, maybe better for the patient, acoustic in particular. But AVM surgery is not a piecemeal resection. AVM surgery is not partial resection. AVM surgery is start and finish. Attack and kill the monster. You cannot maim the monster. You cannot paralyze the monster. You cannot half remove the monster. You have to completely demolish the monster. And if you demolish the monster, if you are able to demolish the monster, you give new life to this patient. And there is no question. We have come, you see, ultimately towards the superior sagittal sinus, and this AVM is beautifully and completely removed. And that is the patient completely cured following surgery. Now, this is another patient. You see, preoperative embolization has been done. Now, you will ask me whether this preoperative embolization has helped you or it has not helped you. And I will give you my honest opinion that preoperative embolization, I do several cases where there are preoperative embolization has been done. Because I work in a department which is one of the leading departments in the country where interventional radiological procedures are done. And many patients come to me with preoperatively embolized or partially embolized. There is no question partial embolization is good for the patient or not good for the patient. There are several articles written that the bleeding rate after partial embolization may be more than non-embolized patients. Embolized patients are not even good for radiation treatment. So partial embolization, preoperative embolization is, I am not absolutely sure if I do preoperative embolized patients, but it does not really make my surgery very easy or safe. And this is post-operative. I remove this embolized AVM beautifully. This is another AVM which I have recently done during the COVID times. This was a, I will say, quite a straightforward AVM because anterior cerebral artery is the main feeder. You see, when I operate this AVM, my exposure has to be from here to here. The whole thing has to be exposed. I come from here, get to the feeder, and then you see, remove this AVM, and you can remove this AVM. This is, of course, this is another AVM. I did this patient. I am not sure whether I should have done it or not. This patient comes to me with the only complaint of giddiness and very bad giddiness. And the whole family is, troubled by this lady because continuous giddiness, she's not able to live. So I operate this patient. Now you will say, whether it's such a large AVM, whether you will like to operate. You see, there are good points in this AVM. Now you will ask me, what are the good points? One is large anterior cerebral artery. Is a good point for me. The second thing is large posterior cerebral artery. Very good point for me. I come interhemispheric, get the anterior cerebral artery, and then get the posterior cerebral artery. Both these arteries I can get from interhemispheric before I touch the AVM, and then I circumferentially resect, and then of course I have to, but this is a high flow AVM. You see large intranidal aneurysms and things like that. I cannot show you the whole AVM surgery, but come interhemispheric, retract the brain, come interhemispheric, get to the anterior cerebral artery feeder early in the operation. If you have doubt, put the temporary clip or a permanent clip. You see, this is a little bit oldish oldish video of mine. First, I am getting to the, you see my right hand, I am holding the suction because I am dissecting with the right hand. It is more powerful to suck if I am able, if there is a bleeding, if I am having the suction in my right hand, I can suck it more strongly. And then with the right hand, I keep on dissecting, then identify the AVM, large feeder, and then of course, then identify, cut, dissect, bleeding here, bleeding there. You have to control the bleeding. You have to control yourself. It will bleed furiously. Believe me, AVMs will bleed furiously. And I am not showing probably the bleeding situation, but they will bleed from here, they will bleed from there, and they will bleed from several points at the same time. And you have to control yourself. You have to control your assistant. Your nurse has to be perfect. Your assistant has to be perfect. Your anesthetist has to know you. They have to prepare for blood loss. Sometimes it will bleed from several occasions and you have to control bleeding. And that bleeding will not only disturb you, but disturb the patient all right in his sleep. But the anesthetist will get trouble. And if you are struggling too much, you know, if you are strong and controlling, you are a tiger. You are a beautiful surgeon. If you are not controlling, the whole theater will say, oh, this bleeding is not getting control, and whole theater will start getting disturbed. You have to control the bleeding. In a difficult situation, I am telling you, AVM surgery is a monstrous surgery. AVM surgery is a difficult, dangerous surgery, but it is a beautiful. I will tell you, for me today, AVM surgery gives me the maximum kick before the operation. But you must remember, giving kick is all right, but getting kicked out of the operation theater is also possible in AVM surgery. You see, after getting the whole AVM, I am just putting a ligature around the AVM, and then I ultimately reset this AVM. And this is the patient, and this is the post-operative angiography. I have to tell you, these are very satisfying operations. These are beautiful operations. The question is only one. The question is only one, whether you can do it or not, and whether you can do it safely or not. So this is another AVM. You see, good points, large anterior cerebral. Good point, large PCA. Good point, interhemispheric. And you have removed this AVM. I will say this will come in the domain of relatively easy operation for me today. This is tentorial AVM, quite a high flow AVM, I must tell you. And this AVM I removed quite fantastically, and there's no question. This is another AVM in the motor strip. I will tell you the story of this AVM. This was a high profile person. High profile means this patient had come through a very important minister of central government to me, and multiple phone calls from here and there. The patient having only convulsion in the motor strip. Motor strip AVM and delicate area AVM, you have to work in a very defined subarachnoid plane. You cannot take the brain outside the AVM and do the dissection. Other areas, you can definitely, no question, you can take the brain whilst dissecting and getting to the feeder. And if you don't want to do, you will not be able to remove AVM. But motor strip AVM, you have to dissect in subarachnoid plane, get to the feeders, get to the vessels. And I removed this AVM beautifully, as you have seen here, but this patient developed quite a bit of hemiplegia following surgery, hemiparesis following surgery. Rapidly improved, rapidly improved. Speech recovered quite fantastically. Not quite fantastically, he remained quite badly crippled and brutalized, but he recovered. I must say that if I had not operated, I operated this patient several years ago, still I get troubled when I see this patient and he comes to me in a hemiparetic gait. He's walking around, but his speech is also not good. So this is one complication I had, but he never had any convulsion after surgery. This is a motor strip AVM, comes hemiplegic to me after surgery. My strategy is, first I have to decide whether I will be operating on this patient or not. That is one thing I have to decide. If I leave this patient in 2 months, this hemiplegia will recover, that is for sure. Whether I should operate after 2 months or whether I should operate within 1 or 2 weeks. Earlier, I used to operate after 2 months when the hemiplegia has recovered. But now, if I have decided to operate, I will operate early following bleed, because if the patient has hemiplegia, these patients can certainly develop hemiplegia following surgery. So it gives me some kind of a relief that the patient will not be too much terrified that he was not hemiplegic before operation and has become hemiplegic operation. For my own safety, now these patients I like to operate in the early post-operative phase, maybe within a week or so. So this was the large AVM, and this was the post-operative AVM following surgery. He did not develop any post-operative weakness and was in quite a good shape following surgery. This is another AVM. This is post-operative. This is distal MCA. And you can get to this AVM. This is post-operative. Good points in the AVM you have to identify. Several bad points in the AVM you should not operate. Good points for surgery you have to identify and then you have to remove. So this is another AVM. Good points for surgery are when the MCA vessels feeding is a distal MCA, not in the eloquent area, not in the dominant hemisphere. Same AVM in a dominant hemisphere may be a dangerous surgery. So these are identify good from bad and then you remove. So this is another AVM. You see this AVM and I remove. There is some lagging of hand here, but this AVM is completely removed. I must say one more thing. AVMs in children look more dangerous. They are more easier to operate. AVM in more adults or elder people are little bit more trickier to operate. But in children, it is better to operate. So this is one more AVM. So I make this 3D model in the region of posterior cerebral artery, in the region of anterior cerebral artery feeder. And this model will determine, you see, how to operate and how are the feeders. And you can have a good strategy, draining in the vein of Galen, straight sinus and things like that. And this is post-operative imaging showing the resection of the AVM. This is one more AVM, and this is post-operative. You see the distal MCA, get to the feeder, dissect the AVM, learn the art of identifying normal from abnormal. That is a very important. Learn the art of dissecting, learn the art of opening in the subarachnoid plane, getting normal from abnormal, and getting to the feeders is a critical issue. So this is another interhemispheric AVM. I have already told you that get to the feeders, and I will categorize this AVM is although in the region of medial motor strip, can be dangerous for the legs, but operate in the subarachnoid plane. Start from here, and then come from here and circumferentially dissect this AVM. And I will say this AVM is a beautiful AVM to resect. And I did this. This is the child post-operatively. This is the AVM you see before operation. You make a 3D model of this. And this is the model. It will give you from which vessel to identify first and dissect. And then I operated this patient. You know, this is also some years ago. I did this from contralateral interhemispheric approach. Actually, I did bilateral interhemispheric approach. I approached first from the contralateral hemisphere, which I described this approach first time in the literature. Contralateral interhemispheric approach for AVMs. There is one Mexican doctor who described contralateral. I described bilateral interhemispheric approach. So you see here, this is my article. I first approach the artery from here, then I approach the AVM from here. So this contralateral and interhemispheric approach is an option. I must also tell you, I do not use contralateral approach very often these days. This is another AVM which I use contralateral, but I will say contralateral and bilateral is okay, but ipsilateral, wide exposure, anteroposterior, get to the anterior cerebral is a better option. Contralateral approach may not be such a great option. And here my friend Pise is also feeding the AVM. Come interhemispheric, get to the feeder, and then you will be able to get a beautiful angiogram. All right, but you have cured the person. This is another AVM. You see the AVM location in the velum interpositum, in the region of vein of Galen. But you see my beautiful friend here is anterior cerebral artery. And my other very fantastic friend is posterior cerebral artery. Dissect. You see here, anterior cerebral artery, big feeder. Posterior cerebral artery, big feeder. And this AVM I will categorize even in the location of vein of Galen, even in the location of internal cerebral veins, quite a safe AVM. And you see this is the AVM which has been resected. I wish I could have shown you the video of this case, but unfortunately I cannot show. These are long operations. This is another AVM. Patient comes with convulsions, multiple convulsions, temporal lobe AVM. And this is a difficult AVM, a huge AVM. You cannot say I will do, this is not a meningioma. This is not a piecemeal resection. This is not a, this is a surgery which is meant to be removed. And this is meant to be an aggressive resection. And this has to be a complete resection. So here is the AVM which has been completely and beautifully resected. And I must tell you that you have the power in your hand. You have the power in your hand to cure. You have the power in your hand. If you think, no, difficult, dangerous, I will not do it, then don't do it. Please don't do it. If you think acoustic tumor is a difficult, dangerous tumor, don't do it. If you think cavernous sinus is a dangerous tumor, don't do it. If you think motor strip glioma is a difficult tumor, don't do it. If you think everything is difficult, then don't take neurosurgery. Neurosurgery is difficult. Neurosurgery is complex. Neurosurgery is a challenge. If you want to accept, accept. Otherwise, don't do it. This is another patient comes with, I did it long time ago, only issue of convulsions and quite a dominant hemisphere. You can imagine subarachnoid dissection, get to the feeder and remove this. And this is post-operative angiography. And this is the AVM. This is another AVM with anterior cerebral. I will say, I thought that this is very straightforward AVM for me, but this turned out to be extremely high flow AVM. But extremely high flow or low flow, that doesn't really matter. When it is flowing, you have to flow with the AVM and you have to get the AVM. Question is whether you are ready or not. This is another AVM in the, here I don't remember many of these cases. You see, this is also, I think, posterior circulation, not posterior circulation, posterior cerebral, large aneurysmal dilatation of the AVM and remove. This is another AVM fed by the anterior cerebral artery. I don't remember these AVMs now. If you say how it bled or not, what, I don't remember. The bleeding has been in my life. I do 5 or 6 or 7 or 8 cases in a day. Today I did 5 cases in the morning. 2 acoustics, 1 craniovertebral, 1 pituitary, and 1 colloid cyst in the morning. So I do, AVM is not a single case I do in the day. I don't remember what happened during this operation, but this was removed beautifully, you see, and I can say AVM surgery, you will get results which you have not imagined before operation. AVM outcome, there can be complication. In neurosurgery, there have to be complications. But if your complications are there in every case or every third case, then you should not, certainly you should not enter into this domain. So this is another AVM. I thought this is in frontal brain. I thought it will be quite straightforward, but this was also quite high flow AVM. I am telling you, I don't remember many of these cases, but I also remember that some patients were high flow and that this patient was a high flow AVM, which was removed. This is another AVM, and you see this AVM and post-operative image. Looks like a straightforward image. You see, this is temporal AVM. This is the Sylvian fissure. The vessels will come from the Sylvian fissure to the AVM. Get that vessel. If you take the middle cerebral artery, you have killed the person. You have made hemiplegia. You identify the vessel, you come to the vessel, come close to the AVM, then cut it, identify it, and then you get, you can remove the AVM. This is another AVM here, and this is the post-operative angiography. This is another AVM where I created a disaster. You see this AVM region in the region of middle cerebral. Long time ago, I operated this AVM with very high flow AVM. And you see, this is the post-operative, but you see, there is no middle cerebral artery here. And there was a middle cerebral. This patient, surprisingly, I don't remember this, whether this patient created, it was hemiplegia, whether he recovered or not, I don't remember, but I think I have damaged this person. This is another AVM, and this AVM, you see this AVM, and you see this AVM beautifully removed without any question. You have given a new life to this. This is another AVM. This is another AVM which was in a nun, middle cerebral artery, and almost like a, let me show you some beautiful dissection. In the region of Sylvian fissure, I come, I dissect. You see my right-handedness, suction in the right hand. You have to dissect. You cannot take a normal vessel. If it is bleeding, you cannot just coagulate the whole brain. If it is bleeding, you dissect around the bleeding till you get the main feeder. If it is bleeding heavily, don't get restless. You have to be prepared for heavy blood loss. And you have to be prepared for a cure. If you are prepared for a disaster, then you will create a disaster. Your assistant, your nurse, your anesthetist should know you, and they should know you very well, and they should have a confidence in you. If they don't have confidence in you, and if you don't have confidence in your own self, then only God can help this patient. You should be supremely confident when you are operating on such a case. You see, now I have held the AVM, and I have held this multiple large loculi of the AVM. And I must also tell you that these AVMs, if they are taking 20 hours to operate, then you should not operate AVMs. Get to the site of the vessel. If you have got to the site, then coagulate the vessel and cut, and then dissect. Coagulate, cut, dissect. Coagulate, cut, dissect. Get the large vessel, get the small vessel, get the medial vessels. Don't get the small vessel. Small vessel is divine. Small vessel will lead you to larger vessel. Small vessels do not need any kind of coagulation at all. Small vessels will lead you to the large vessels. If you do not know small vessels, do not touch AVMs, because you will create a disaster. And this is the AVM which has been removed, and this is absolutely cured. This is the AVM which has been removed and cured. You see large AVM, then you cut and see almost like this. I have already shown you. This is already, I have shown this image, I think, may not be, but see the beautiful, beautiful. And you see this patient has come, I'm not sure if it has come with bleed like this, and there is a large venous loculation. This is a mixed of pile AV fistula and AVM. So I have got a new entity, pile AV fistula and AVM together. This is another AVM in the motor area. Have the guts to remove it. This patient had come with hemiplegia. He remained hemiplegic after surgery. But I now watch him after 20 years or 25 years after surgery. There is no question of hemiplegia. He's completely cured, and he's completely normal life. This is another AVM. You see, I'm showing you what I'm showing you. I'm showing you what I've done. And I will show you what I have not done. I am showing you some AVMs which I have done. I'm showing you AVMs which I thought could be done. And I'm showing you AVMs where I found some weak points in the AVM, which are anterior cerebral feeders, middle cerebral, peripheral middle cerebral feeders, PCA feeders, which can be accessible and which can be done. So this was done. And I will show you some AVMs which should not have been done. This is another AVM, multiple convulsions. This young girl, little bit tricky AVM. You see, you could have damaged the person, but I did it beautiful, beautiful. Dissection, dissection. Learn the art of handling the bleeding. Learn the art of dissection. Learn the art of subarachnoid dissection. Learn the art of aggressive dissection. Learn the art of identifying normal from abnormal. Learn the art of identifying large vessel bleeding, middle vessel bleeding, small size bleeding, and you can certainly. Now this, I will give you another situation. This patient bled, and some doctor did a big decompressive craniectomy. I will never advise anybody to do a decompressive craniectomy for AVM. Never do it, because if you do, you have harmed the interest of the patient. If you do not want to touch this patient, do not touch this patient. If you do not want to, but do not do this decompressive craniectomy. So he came with the decompressive craniectomy, this AVM. Then I removed this AVM and I did this. He had put the flap in the abdomen. I replaced the flap. I will say, do not ever, I will never recommend decompression for AVM surgery. This is another patient. This patient comes to me in a deep, not deep, but quite deep, in a deep unconscious situation. But when I see this AVM, I find some wonderful points for me for surgery. Wonderful points like anterior cerebral artery, large, this, large. You see, I find that if I come in this area, I can dissect and remove this AVM. So I find some wonderful points in this. Although the patient had bled and was unconscious. And I removed this AVM. I removed this AVM, but I could not save this patient. He never recovered. But I'm showing you that this was the AVM where I thought I should remove this AVM even if the person is unconscious. And I removed it, but I could not save. But the question is, I removed it beautifully. This is another AVM. Of course, now I have talked many times about posterior cerebral artery, and I am sure you will now realize, and those who are watching me today will also find this AVM easy now. I know these are AVMs. Some of you will say, yes, posterior cerebral, I'll come and remove. Yes, you can come and remove. No question. This is easy AVM. And if you are a strong neurosurgeon, if you are watching AVM surgery, I'm sure you are watching because you are a strong neurosurgeon. If you were a weak neurosurgeon, you would have gone to alternative meetings which are going on now. Because you are watching this AVM symposium, this is an AVM operation. This is another PCA territory. Yes, you can do it without any question, and this is post-operative. This is another, this is, I have already shown you. This is another posterior cerebral territory AVM which is removed, and you must come interhemispheric, get to these feeders, and you have now, those who are watching me will now realize that these are AVMs which are easier to remove. Now I will go to a story of a mathematics teacher in India. This was the AVM. You see, there are several feeding artery aneurysms in the basilar trunk, in the basilar trip, PCA, this, and this patient had furious AVM. Posterior circulation AVM are relatively simpler AVMs. I must tell you, don't get scared. If you are scared with AVM, of course, you have to be scared and you have to be truthful and honest. You should know your own skills. You should know your own potential of controlling bleeding. Because if you realize that potential before operation, it will help. But if you realize that potential during operation that I have no art of controlling bleeding, you have killed the patient. Because if it bleeds and you cannot control, then there is no option. So this AVM was embolized during that time on several occasions. And then I put multiple clips and I removed this AVM. This is post-operative. And I must tell you that this mathematics teacher is doing good mathematics teaching in interior of our country. And several times he calls me, and he asks me some strange questions which are difficult to even understand. This is another AVM. You see, this AVM is having flow in the superior sagittal sinus, retrogressive flow. I operated this AVM some 25 years ago beautifully. I lost this patient for follow-up. So there are posterior circulation AVM. I will range this AVM into territory of easy operation, because you see the cerebellar AVM, you can sacrifice some cerebellum. You get to the superior cerebellar artery, circumscribe, get on the dome of the cerebellar hemisphere, get to the feeder, and circumferentially dissect the AVM. I will say that even the people who are watching me today will realize that this is not such a dangerous AVM. This is another AVM, of course, I have shown you already, sorry for that. This is AVM, which is in a very high profile film actor of India. This is the AVM being fed by the PCP pica, and the draining veins are going to the trigeminal nerve, and this patient comes with the symptom of trigeminal neuralgia. I remove this AVM, he's cured completely, and I become instantly famous in my country. Intraventricular AVMs are relatively good AVMs to operate. Intraventricular are coming from anterocoroidal artery or posterior choroidal artery. They are into the choroid plexus of the AVM, and you get to this AVM and you can do a good job and you can do a safer operation. This is another temporal horn AVM. You see it coming from the posterior choroidal artery. I get to the posterior choroidal artery, and this is relatively simpler AVM. This is velum interpositum AVM. He has come with a big bleed, velum interpositum. Now you have to know your anatomy beautifully. You have to know your anatomy perfectly. If you are not in anatomy, you cannot do this AVM. I must tell you, you have to know your anatomy of velum interpositum beautifully and perfectly if you have to even think of operating on such cases. You see this AVM here, this AVM, and this AVM coming from the posterior circulation, and I did this beautiful resection of velum interpositum. Beautiful resection. I get a kick out of this AVM surgery, and there is, you can get kicked out by the patient and by the family. This is intraventricular AVM. I have a video of this, but it is not properly edited, so I don't want to show you. But this is intraventricular, and this is post-operative, beautifully resected. Here I can show you some blood clots, what my resident has given me. I will never remove AVM in such blood clot kind of, but it is not always necessary to remove it en masse. So this was removed piecemeal AVM. This is another AVM close to the vicinity of the ventricle, and this has been removed beautifully, as you have seen. And here also my friend is coming in picture. This is an AVM, you see, whether it is intraventricular or extraventricular. That has to be very clear. These are lenticular striate artery feeding or choroidal feeders. You see, I will show you, this was removed. Now you see here, and you have to do elaborate investigation. You see this? Now, if it is lenticular striate, you should not even touch that. If it is choroidal, you can easily remove it. So this was removed. So whether it is intraventricular or extraventricular is very, very critical to understand. Now I want to ask you a question, whether it is easy to remove this or difficult to remove this AVM. I will say this is not an AVM. This is a pile AV fistula. This is the large vessel. This is the fistula, and this is the drainer. You coagulate this vessel here, you coagulate and finish, and the AVM, this pile AV fistula is finished. So this is the AV fistula. I was not knowing this. I thought this whole thing is AVM, and I dissected it completely, and this was not necessary. You coagulate here, and that is the end of the story. So this is the surgery where I, unfortunately, I'm not able to open it, but I did not know that just coagulation of this will be sufficient, but I did this surgery and I removed the whole thing. This pile AV fistula, there are multiple stages of blood coagulation within the pile AV fistula. This is also a pile AV fistula. You see, just come and coagulate here. If you put onyx here, coils here, not necessary, but you can come endovascularly and put coils, but those coils can be sucked inside the superior parietal sinus and you can create unnecessary issues. Just come and coagulate here. Very simple, straightforward surgery. This was another pile AV fistula which I removed. But I have to tell you, it is not necessary to remove a pile AV fistula. This is another pile AV fistula, which is beautifully, this is a 3D model, and this was removed by one of my associate doctors and emerging power in neurosurgery, and this is completely removed beautifully. This is another pile AV fistula. Don't mistake it for an AVM. This is come and just coagulate the feeder, and there is no need to remove it like this. This is, I removed it at that time, but I don't think. So I reported 14 cases of pile AV fistula, and now I am having multiple numbers of pile AV fistula, and now I am having another clinical entity by the name of mixture of pile AV fistula and AVM, which I am going to report very soon. This is a pile AV fistula in a very small little child and huge veins and all. Now, what you will do, if you put onyx or some coil here, it will be sucked inside the huge vein. You just come and coagulate this. I clipped this, and this rapidly, this pile AV fistula finished. This is another case of pile AV fistula. Scalp AVMs are a different cup of tea. You can remove scalp AVMs by just pressing the feeding channel and then removing. And my friend Binzu has done several scalp superficial temporal artery dissections. He knows exactly. So AVMs can be a progressive in size. AVMs can grow during their lifetime. Now there are several AVMs I will show you now, which you should not touch, or at least I have not decided not to touch. So this was one coming from huge nidus, I should say. And whether I should subject it to radiation, no radiation. Whether I should subject it to embolization, no embolization. So if I am not ready to operate this patient, I will suggest don't do anything. This is another AVM in the thalamic region. You see, now in retrospect, I identify some good points in this AVM for surgery. You see, my friend is here, posterior cerebral artery. I'm wondering whether I should have operated this patient, but I did not operate, and I am having this patient living perfectly healthy without any symptom for good 7, 8, 10 years. Whether radiation gamma knife would have helped this patient, maybe yes, but no treatment is also very effective in AVM surgery. AVMs in the region of brainstem should not be touched, even if your friend is being shown in its magnanimity. But I do not recommend AVM surgery. Now, this AVM, don't give it embolization, don't do radiation, nothing should be done. This AVM also, I did not do anything. I will not subject this AVM to any kind of treatment. So you realize what I'm trying to say. I am trying to say surgery or nothing. Surgery curative, nothing not so bad. This is another AVM which I did not do anything. And this patient also, I have long-term follow-up of these patients. This patient, nothing to be done. No surgery, no nothing. This patient also which bled into the brainstem. When it bleeds into the brainstem, even if it has a devastating neurological deficits before operation, I have not touched this AVM, and this patient rapidly recovered after operation. So there are some instances which I do not recommend surgery. What about embolization? Whether embolization has a role in AVM's treatment, I will say it has a very questionable or doubtful role in AVM treatment. This is my opinion. I am not saying you follow my opinion and you stop doing embolization. You please go ahead and do whatever suits you. Whether it helps in surgery, I think it does not make a difficult AVM easy. Whether partial embolization is helpful is a very negative influence and has a number of potential complications. Like here, the patient was embolized, huge bleeding, hemiplegia. Then you see, then I operated, removed this embolized AVM. Hemiplegia also recovered. But you see, there are potential problems in embolization. This, if I had operated without embolization, maybe. I'm not saying always, but may not be hemiplegic after surgery. This AVM was embolized till the time he bled, and he bled furiously, and then he came to me in an unconscious situation. But I was, a young boy, very ready to remove. I removed that AVM, but this patient never recovered and he died. So thank you, my dear friends. I hope I have given you some information about AVMs. It's a different world of neurosurgery. It's a great world of neurosurgery. It is our world of neurosurgery. It is my world of neurosurgery. It is your world of neurosurgery. Accept the challenge. It is a wonderful challenge to accept. Neurosurgery is a complex subject, difficult subject. You have to be beautiful. You have to dissect beautifully, and you will come out with wonders. And I hand over the mic to Juha, who is the king of AVM surgery, I know, and the whole world knows that he is the master of AVMs and a person who has taught the world the art of fine microneurosurgery, the art of beauty of microneurosurgery. Juha, over to you. Thank you.
Thank you, Atul, for a wonderful lecture. I was so excited. My adrenaline level rose extremely much. So I totally agree that you should not touch the AVMs if you are not 110% sure that you can take it out. So never begin AVM surgery if you are not sure that you can fight until the end. You have to be like in the beginning of that kind of large AVMs, you have a feeling that you are the greatest neurosurgeon in the world when everything goes well. And then at the end, when you are coming to the deep points with bleedings, so you have the feeling that you are the worst neurosurgeon of the world. And then you have to manage this situation, this psychological situation. You have to continue. When I was small, we used to throw the cat on the wall, and the cat is not falling down, it's sticking to the wall, and the neurosurgeon should be the same. So you never give up, you never fall down, so you stick even to a very all kind of wall. You are not falling down. This is very important. So don't give ever up. This is the most important thing. So, and then finally the AVM is surrendering. So this is a wonderful feeling when you see that the draining vein is getting slack and it changes the color, and then you can take it and take the AVM out. This is wonderful. So you will really get kicks in the AVM surgery, and the outcome is of course good because it is not a malignant tumor. It is a benign lesion you can remove, and the patient is recovering and doing well. And if you have complications, hemiplegia or something, then the patient remains long time alive, and you remember that all of your life. When you get older, your conscience is getting more and more bad, and you remember those cases, and they come in your dreams and days, and you remember those cases. And like I was operating on a young ballet dancer, 23 years old, and huge parietal AVM. She was doing well. 3 or 4 days after surgery, that time we used nitroprusside to lower the blood pressure. And then on Saturday I was on call, and then I closed the nitroprusside drip, and I told we don't need any more of that. This was the 3rd post-operative day, and she was doing well. And then in 30 seconds she was deeply unconscious and dilated pupil, and I rushed to CT and then to operation room and took a big hematoma out. She remained hemiplegic, and she came every year to the outpatient clinic and was crying. After 30 minutes she was crying deeply, and I was holding her hand, and nearly crying also, and so it was extremely sad experience. So that kind of experiences, I have done more than 600 AVM, so you get those complications. You remember them better, like you told that you don't remember all the cases because they went well. You don't remember the good cases, but the bad experience you remember extremely well. And this is very important. I was wondering, why are you using the right hand? Are you left-handed or right-handed? Why are you using the sucker in the right hand?
See, I find, you see, when I use right hand, I can control the bleeding properly. You see, I can suck the blood more strongly with my right hand. And my right hand, my suction is, it is, I can maneuver my suction. I can dissect with my right hand with 0 power. And I can make it 100 power. So with my thumb, I can increase or decrease the power. And with the left hand, I dissect. So this is a little bit different because I find it very useful in vascular situation. In aneurysm, of course, I will use my suction in the left hand and dissect with the right hand. But for AVMs, for cavernous sinus surgery, for petroclival tumor surgery, for difficult tumors, for vascular area, I think I use both the hands, not just the right hand.
But your both hands are as good. So,
So
by manual.
I am right-handed person, yeah.
But you can use also left hand very well.
Yes, equal, both hands.
Okay, I think we have a few questions from Radab, a neurosurgery resident from Jordan. Radab, are you there?
Yes, Dr. John. Hello, everyone. Hello, Professor Atul. All my respect and appreciation for the tremendous work and wonderful presentation as usual. So we are honored to have your shared experience as every Friday. So I have multiple questions if the time permits, Dr. John. First, regarding that small vessels, Professor, what is exactly the secret of that small vessels? So what is the key in dealing with those small vessels? This is my first question. And my second question about that, the venous drainage. What do you think is the perfect way to deal with the venous drainage in the AVM resection? Just to leave it in the end, or we have a specific secret or key to deal with them? And that's it. Thank you so much.
Okay. So your first question is the most important and very, very critical and very crucial. You see, when you are operating on AVMs, it will bleed from one point, it will sometimes bleed from another point, and sometimes it will bleed together from 1 or 2 or 3 points. And then you have to select whether I should control this one or whether I should control this one or whether I should control this one. It happens in large AVMs. So you have to be very, very strong in your mind. Which one to control, how to go further. It will not that you are controlling one, it will only bleed at one other side, it is complete hemostasis. So you have to identify which vessel has to be controlled first and then how to go further. So as I mentioned to you, large vessel controlling, because it will furiously bleed into your field, you have to go and coagulate. So it is relatively easier to clip the large vessel or control the large vessel because the blood flow will come very furiously. Medium vessel also, medium vessels are also. Small vessel is the issue. Small vessel, the issue is, small vessel will bleed and you cannot even coagulate those vessels. They will, you born with bipolar, you will not be able to coagulate those vessels. And then they will bleed and then they will burst out and then they will go here and the depth. And then sometimes what you do is you take little bit adjoining brain to coagulate. But what I have realized that these small vessels are the criticalest issue. Believe me, those small vessels, what one has to do is you have to identify that vessel and, follow that vessel to the mother. There will be a big mother snake sitting like a cobra behind. That cobra has to be attacked. And if you go on wasting your time in small vessels, that cobra will be keeping on supplying venom. You understand? So if you have to capture the cobra, you have to identify the small vessel and then get to the tail of the cobra and clip the cobra. You understand? Have you ever caught a cobra or no? You have to.
Not lately.
Have you captured a lion or no? You know how to capture a lion? You have to capture a lion by his tail. You hold the tail of a lion. If you go on the jaws of the lion, lion will eat you up. So hold the tail and don't leave it. So tail is the small vessel of the lion.
Okay.
Identify the tail and enter through the tail. You understand?
Definitely, yes. Thank you.
Second question that you asked me about the veins. Some AVM has a single venous drainage and some AVM has multiple venous drainage. So what you have to do is, if the single venous drainage is there and you coagulate that venous drainage early in the operation, the AVM will, there is a possibility that AVM will rupture. So you should hold on with that vein till the end of the operation. But some AVMs has multiple venous drainage and you have to ligate one vein to get the dissection plane. You cannot say, I will not touch the veins till the end of the operation. It is not like that. So there are occasions when you have to get the vein and get your dissection plane and continue the dissection plane. You understand what I'm saying?
Yes, definitely, Professor. Thank you. The last question was about that PCA. You think that we should always coagulate and cut, or we can apply a temporary clip on that major feeder initially?
See, if you get the PCA, complete PCA, if you ligate, you will get, hemianopia. That vision, that cortex will go. So what you have to do is first identify the PCA and then follow the PCA towards the AVM and get to the feeder and then cut it and coagulate. If you coagulate the PCA early in the operation, you can get the whole PCA infarct. I'm not saying I have not got visual deficit after operation. I have got visual hemianopia after operation. I'm not saying it is not possible. But the best thing is to get to the PCA, then identify the feeder, go along the feeder, cut and coagulate near the feeder, and don't coagulate normal vessel, which is very important in AVM surgery.
Okay, Professor. So you think that we always, once we get the feeder and we're sure that it is one of the major feeders for the AVM or the nidus, we go for coagulation and cutting without clipping? Or clipping is not useful
necessary.
here?
If you are sure, not necessary.
Okay.
So you are still, you have to do many AVMs in your lifetime. So you will get experience more and more sooner. But try it. Don't be afraid.
Okay.
What do you say, Juha? Don't be afraid.
Thank you so much.
I'm always afraid when doing. I'm afraid when beginning the surgery, and then when I get the microscope, then I lose the. No more afraid when I look under the microscope, and then as I mentioned in the beginning, when it's going well, then you have the feeling you are the greatest neurosurgeon in the world. You are the only one who can do it, and then when it begins to bleed, then your mood is going down, but you have to fight. You have to fight then until the end to take the AVM out.
Okay, we have an interesting question from Jack of China. He says, could artificial intelligence algorithms detect the main risk factors of AVMs and pre-surgery planning?
I think it is a good subject, and I will encourage Jack to work on this subject. I have not much idea about what is the real thing, but my feeling is that maybe a potential scope to study in the future.
Okay, very good. Okay, more questions from the panel? Okay. Okay, another question from, well, there's one written question. Kaval asks, what about perfusion pressure back through syndrome post-operative?
Yeah, I talked about this of normal perfusion pressure breakthrough concept. This theory was introduced by Spetzler, and it was a very solid theory. The theory was that when you clip the AVM, because all the blood is going into the AVM, now it will go to the normal vessels, normal perfusion, there will be a breakthrough. That was the concept that Spetzler introduced. But I asked recently Spetzler himself, and also I asked his colleague Michael Lawton, they are themselves not now convinced about normal pressure breakthrough theory. I will of course ask Juha about his comments, but what my feeling is that if you are able to remove the AVM completely, if you have left some AVM behind, it will bleed, and it is a good excuse for the doctor to say it has normal perfusion has broken through and bleeding has occurred. I think it is a good excuse for the doctors. As far as I am concerned, I have operated several huge AVMs. If I have removed the AVM completely, there has never been a perfusion breakthrough. Juha, what do you say about this?
I think there is a small remnant that bleeds.
Yeah.
Yeah, there's a small remnant, like in the case in the ballet dancer I told you, then when the blood pressure went higher, then a small remnant bled, and she had post-operative hematoma. It was not this perfusion breakthrough phenomenon. It was a small remnant I had left there, and small remnants are extremely dangerous. So they are as dangerous as the whole AVM, or even more dangerous because you have manipulated them. About the partial embolization, so in Helsinki follow-up, the long-term follow-up, they bled 3 times more than those without doing anything. So it is a dangerous job to embolize partially AVMs.
So I will, there are many people, young people watching the show. I will like to ask one question and you put on the chat box. All of you, please put on the chat box. Do you think AVMs should be operated? Yes or no? Put on the chat box. I want to see what you are saying.
Okay, while we wait for that, Dr. Goel, Mahesh has a question. Small vessels are difficult to coagulate, and do you think that dirty coagulation is a way to go for these?
I have already discussed this, John.
Oh, sorry about
I have
that.
already talked about it.
I'm sorry about that.
May I say something? I use the dirty coagulation. I take a little bit brain tissue and coagulate the small vessels. But Atul has certainly right that when you are not successful in that, you have to go to the mother of these vessels. And when you find this mother, then coagulate it down, then the bleedings will stop. So this is how it goes. So there's real mother of these small cobras is bigger cobra there. And when you take that, then the bleeding stops.
Yeah, I will ask another question, John, if you permit me.
Go ahead.
There are many yeses are coming on the screen on the chat box.
Okay.
Now I will ask another question. Do you think? No, maybe I'll not ask.
No, go ahead. This is a great platform to interact with the audience.
I will ask whether you will like to. You think AVMs, you see, neurosurgery is a difficult subject. The whole neurosurgery is difficult. There's nothing easy in neurosurgery. Even shunts can be difficult. Even burrows can be difficult. The whole neurosurgery is difficult. All young people and senior people in the audience, I know, they have come to neurosurgery because they have learned they want to accept challenge. They want to accept the most difficult of the surgery. So I wish that you accept this challenge of AVM surgery. But you should be very careful. You know, I must tell you that even if I'm saying accept the challenge, it is not easy. It is difficult. It is dangerous. So you must know and learn and analyze the subject very carefully and then enter into the field of AVM surgery. And I am saying without doubt that AVMs look difficult, but they are not that difficult. They are not that impossible. They are great surgical, you know, they form a great surgical material.
Okay, Dennis asks, what do you think about the Aruba study?
I know Aruba study, there are lots of issues about Aruba. Aruba says don't touch AVMs. I will say if I don't touch AVMs, I leave many people untreated and many people devastated with convulsions all their life, with headache all their life, with potential to bleed and death all their life. If I think I can operate, if I think I can safely operate, I must operate. This is my answer to Aruba. But also if you have no experience or something like that, then you should not operate. Then you do trials. You know, then you do Aruba trials. If you cannot operate, you do Aruba trials. What has Juha to say?
I'm the same opinion. So in the Helsinki follow-up study of AVMs, as a follow-up since Second World War, so total occlusion of the AVMs, they did by far better than those without operations in long term, 20, 30 years or more. So there's a real big difference in untreated and with total occlusion.
I see my friend Victor sitting here. Victor, you have something nice to say.
I'm just enjoying your lecture and your opinions. I think some AVMs should be treated with AVM radiosurgery and some others with surgery. I don't have experience in radiosurgery, but articles describe a good results with this technology.
Okay.
Okay.
Atul.
Yeah, Ben.
Yeah. I noticed you print some 3D model for some cases. So do you really think it's helpful for your operation or just for teaching?
Also for teaching, also for surgery. And also for teaching is a very beautiful tool. And also when you make a 3D model, you know the nature of the nidus. You know, if it is a compact nidus, that information you get from the model. If it is a diffuse, you know, sometimes on angiography, you will see that it is a little bit diffuse kind of nidus. But model shows you a compact nidus. So I have no doubt. And also it is for planning of surgery, for marking your skin incision, how big your flap should be, how big your craniotomy should be. I think, Ben, it is a very helpful tool. And it is the future. It will come into, many people are doing now in craniovertebral junction surgery also many people are doing. And in AVM, I think this technology is picking up. You've been in China, you don't have this technology?
We also have, but I never use it because, you know, I do the angiogram by ourselves, our same team, so we can analyze the nidus on the 3-dimension angiogram. No, sometimes even the 4D dimension.
This is an additional tool, Ben. It is an additional tool. If you want to use it, you can. It is helpful. I think you, to answer your question, it is a wonderful, wonderful investigation. Wonderful.
Okay.
Okay, any questions?
Thank you again for your fascinating presentation. Now, until now, I think it's around 2,700 audience for today's webinar. Yeah, because, you know, there's another one at the same time, the ICCN is the third one. So you still have almost 3,000 audience. So
excellent.
Very attractive. Yeah.
The king stays the king.
Yeah, yeah, yeah.
Okay, and by the way, Ben has translated into Chinese to this audience, so we really appreciate
Takashi,
that.
Takashi, you did in Japanese or no?
I think he got here late. Dr. Takashi?
Good evening. So I attended a little late because I just finished surgery, metastatic brain tumor. So,
okay, the next one.
I've got to say, so the next one. So several Japanese friends. So I'm translating token, translating, and I'm still in the hospital just after surgery. So I have to go to ICU now.
Thanks for coming.
Lecture. Thank you.
Thanks for coming. Okay, and thanks everyone for coming, especially Dr. Goel, and thank you. Juha, what's the plan for next week?
Next week, we have a break for Adol Goel. So Ugur Dure will speak next Friday, and maybe Professor will also join the discussion, Professor Yasakil. So
okay,
exciting. He will speak about the surgery of mesencephalon lesion tumors.
Great, okay, great, and excellent. Okay, we'll let everyone know about that, and we'll close now. Thanks everyone for coming.
Thank you, Joab. Thank you, John.